Hi everyone, my name is Carly Minniti. I'm the nurse educator for lower level 1, the behavioral health unit. I also cover patient observation, float pool PCTs, and other units as needed. Um, I'm going to talk about how to enter a OneLink, when to enter a OneLink, some of the patient observation process, and the psychiatric department referral process. So there's multiple ways to access OneLink, as you can see here, through the Citrix receiver within Epic, which is great because it pulls the medical record number and the information of the patient, and also under the MyHMH, as you can see here. So how to enter a OneLink. So you want to choose the most appropriate OneLink related to the event. Any team member can put in a OneLink. Everybody is educated on it and they know that they're allowed to do that. So it's not just up to the charge nurse, but the charge nurse wants to make sure, you want to make sure it gets done. Check with the team member before the end of the shift. It's also important to make sure all the components are filled out as completely as possible, just as best you can to fill out all of the information that's required. So steps to take if a team member is injured or if a team member has a needle stick or significant exposure to blood or body fluids, because this does happen. And sometimes we panic, we don't know what to do, but here are the steps. So if there is an exposure to blood or body fluids or a needle stick injury, so you immediately want to flush that site, clean that puncture, take care of that first, and then notify your leader. Go to team health, formerly known as occupational health. Most people know it as occupational health. And if it's closed, go to the ED. So you can report to team health from 8 a.m. to 4 p.m. For assessment. I listed the phone number here, so you could give them a call to go there. But after hours, must report to the emergency department. So you just want to make sure you follow these steps, put in a OneLink, make sure everything gets followed up on. You want to make sure that team member gets taken care of as soon as possible after the injury. You don't want to wait till the end of the shift or the next day. It should really be done right away. And it's just important to know that OneLink reporting is very helpful because it lets everybody know what is going on in that area. Some people feel that it could be punitive or like you're telling on somebody, but it's not. It's really not for that. It's not about that. It's just to make sure the necessary steps get taken that are supposed to, and we could notify everybody involved so these situations don't happen again. Okay, so I'm not sure if any of you have heard of WeCare. So the WeCare team, it's like emotional first aid designed to provide crisis support and critical incident stress management interventions for healthcare events that are emotionally challenging and stressful for staff. Some high-risk cases, pediatric cases, patient connects staff to family, medical errors, failure to rescue, first death experience, unexpected patient demise. So these are just some examples of high-risk cases, but it's not only these cases. Anybody could be emotionally affected by things that happen while we're at work, with our patients, with the visitors, families. So it's sponsored by Hackensack Meridian Health. It's not a mandatory thing, but it's just something that's offered to help. WeCare team interventions are based on supporting second victims. Participation is completely voluntary and confidential. You don't have to tell anybody you're doing this. It's peer-to-peer support assignments, so they'll be matched to facilitate similar professional types working together when possible. So WeCare services will be available as a staff benefit on an as-needed basis, 24 hours a day, 7 days a week, by just a phone call. Like I said, it's voluntary, non-mandatory. So it's just something to think about that could provide you or a team member that emotional support. If you see somebody's going through a stressful situation, you could refer them to WeCare. It's really important that everybody knows about this. Okay, so I'm going to move on to patient observation. So why do you have to know this as a charge nurse? Most of the time, charge nurses might be making the assignments, and if they have a lot of one-to-ones or safety companions. So we want to know the differences between, a safety companion and a one-to-one. So as I've listed here, safety companion is a nurse-driven order, where a one-to-one for harm to self or others, suicide risk, is a doctor's order. So the one-to-one for suicide risk or harm to self or others is the highest level of observation. So there's more interventions involved, more paperwork involved, more assessment involved. As you could see here listed in the bottom right corner, you will need a communication tool, patient observation sheet, 15-minute form, and an environmental safety checklist needs to be completed. Now, for a safety companion, it's really just important to have that communication tool given to the patient observer. The patient observer is instructed to see the RN before receiving the assignment. So the patient observer might be waiting, at the nurse's station to get report from the nurse before accepting that assignment, and that's their right. They should really get report from the nurse. They're not really supposed to be getting report from the previous PCT or patient observer. So it's just important that they do that, because you want to give them the most accurate information so they can do their job the best that they can. And we also want to reassess every 4 hours for the need for the safety companion or for the need of the one-to-one. On the 15-minute sheet, the RN is supposed to sign every 4 hours that the sheet is being completed, that they're looking after the patient, making sure it's still necessary. And for the safety companion, it's filled out in Epic. There's a 4-hour assessment, and I'll show you that moving forward here. Video monitoring would be the lowest observation level. If you think a patient needs this is also a nurse-driven order. It's, reassess every 4 hours. You want to renew the order every 24 hours, and you want to fill out the video monitoring request form and make sure you're communicating everything with the patient observers or PCTs that are in the video monitoring room. So this is just a picture of the patient observer communication tool. Often this can get missed, but it is very important for the patient observers to know why they're watching that patient and any restrictions that the patient might be on. So this is given to all patients, whether it's a safety companion or a one-to-one. They really need to know why they're watching that patient. So this form here, it's called the Patient Observation Documentation Final, and this is only for one-to-one patients, the highest level of observation. So patient observers can be assigned to 2 patients if they're in the same room and if they are able to watch both patients at the same time. But they cannot watch 2 one-to-one patients. So they should never be watching 2 patients and given 2 of these papers. It's really just one of these for 1 patient. So like I said here, one observer cannot be watching 2 patients and filling out 1 or 2 of these forms. It should never be that way. They're only filling out this form once and watching that 1 patient. And the nurse is to sign off every 4 hours all the way to the right where it says RN initials. So there will need to be a new form provided each day. You will need a doctor's order every day to renew this. Here's just some of the Epic documentation. So you want to make sure you're selecting the correct observation status for the patient. Environmental safety checklist is listed here, so that's only for one-to-one patients, but it needs to be completed at the start of the order, start of the shift, and anytime there's a change of observer. So it's more than likely that you'll have more than 1 observer on a 12-hour shift. So this would need to be done twice. And the patient observers are instructed on that as well, but is RN's job to fill it out in Epic. And for the safety companion assessment here on the bottom, needs to be completed every 4 hours. Okay, so here's just some guidelines for transferring patients to inpatient behavioral health. Lower level 1 at Riverview Medical Center. Lower level 1 is expected to close. We don't have an exact date yet. They're thinking it could be sometime in the summer of 2023, but we still don't have a date yet. But it's important to know that a lot of these same policies apply to the other hospitals. So if you were transferring a patient to another hospital on a behavioral health unit, it's more than likely that these same policies would still apply. So you want to make sure that the psychiatrists and medical staff coordinate the transfer to lower level 1. the patient's medically cleared for transfer to lower level 1. They must be medically cleared. They cannot have things such as Foley catheters, IVs, any medical devices really aren't allowed down here. There's 2 pages to the consent form, the voluntary consent form. They must agree to voluntary admission, and that must be faxed down. You also want to make sure they have a bed available. The patient cannot be transferred without an admitting order from a psychiatrist. And the nurse will obtain the admitting orders from the on-call psychiatrist. You want to notify admitting of the discharge. In most cases, it's not considered a discharge if it's within the hospital. It would be considered a transfer, but you just have to check with the nurse. Pre-cert if needed from the insurance company. The provider will determine medical orders, which should be continued, and those that need to be discontinued. So you just want to check on all those orders, because a lot of things that they're having done on the medical floor might not apply down here once they're medically cleared. And like I already said, all telemetry, IV orders, strict INO, this should all be discontinued because these are medical necessities. Everything IV access, that should all be removed. Patient should really be ambulatory, able to self-propel in wheelchair or walker if they are using those devices. They must really be able to attend groups and participate in their care, because that is a big part of care on lower level 1 and the behavioral health units. There's no grab bars or handrails or side rails on the behavioral health units. So we want to make sure that they're going to be able to remain safe down here in lower level 1 or other behavioral health units. So that you want to make sure they remain in their gown and slippers, slipper socks, non-skid socks when they transfer. A lot of patient's own clothing might not be appropriate down here. So that's why that we say to transfer them in gowns and the slipper socks. Then we could check the belongings when they get to the behavioral health unit and see if they're appropriate. Because in most cases, they can wear their own clothes if they're appropriate. So you want to make sure that all patient items are sent and given to the staff, and that they should be checked. They shouldn't really be on the patient. We want to make sure that they're given to another staff member to check. They really don't require a lot of clothing down here. There's limited storage, but we do have washing machines that they can use and dryers. Thank you, everyone.